for the next session Dr. Amit Bhandarkar and Dr. Pradyumna Mamtora, sir, to come to the stage and start the proceedings. The convener for the next session are Dr. Gautam Zaveri and Dr. Arvind Kulkarni.
Gentlemen, it's a great pleasure to be here at WIROC, and without much ado, we'll start with this session. As you all know, our practice is changing. There was a time when in 2000, the average age of the patient we saw in our clinic was 40-45. Today, the average age of a patient we see in the clinic is about 65. At an average, we see about 3 to 4 osteoporotic fractures every week, and probably operate at least 1 or 2 patients with osteoporosis every week. So the numbers are increasing and this problem is increasing, and therefore we decided to have this session to give an idea to the general orthopedic surgeon how to approach patients with osteoporosis involving the spine. And we've got a very eminent star faculty panel here. And with me, first speaker is Dr. Arvind Kulkarni, who has done some very innovative work on osteoporosis as to how to diagnose osteoporosis. Arvind.
Thank you, Gautam. Thank you for also being a co-convener. My dear friends and colleagues. So the pandemic of COVID is almost disappeared. We tend to have these kind of pandemics which come and go, but the pandemic of epidemic is here to stay forever. So it is very relevant that all elderly patients are screened for osteoporosis. This has been resounded again and again in literature, and this is a recent statement by a group of specialists consisting of spine surgeons, neurosurgeons, endocrinologists, rheumatologists, etc., who have all recommended that every elderly patient should be screened for assessment of osteoporosis. Now, why is this particular age relevant to spine, this elderly age group? See, most of us practice degenerative spine, and about 70 to 80% of these patients fall into this osteoporotic group. So this condition becomes a common denominator for all such patients. So that's why it is relevant to our practice. This is the age when patients come with vertebral compression fractures. This is the age when they come with complex lumbar canal stenosis. Complex lumbar canal stenosis is wherein we need to correct the deformity or instability. So we need to put screws and rods. So that's why it is relevant. We need to have good hold of these implants. Again, same applies with adult spinal deformity, which is a challenging situation where we tend to depend on implants and their hold into the vertebral body. And large majority of these patients tend to have flexion dominant pain. That is again because of a poor trabecular bone. So if you don't diagnose these patients well in advance, you will face all these issues. There will be pedicle screw loosening, instrumentation failure, AVN. These fractures don't heal, leading to AVN and subsequent bigger surgeries. Proximal junctional kyphosis, which is one of the burning problems that spine surgeons face now, is mostly relevant to osteoporosis. And when you do revision surgery, for all such situations, again, osteoporosis becomes relevant. So these patients, these bunch of patients who have this degenerative spine, who need surgery, come to us with the baggage of comorbidities already. They have all kinds of issues: diabetes, hypertension, renal failure, kidney, all kinds of medical issues one can think of. On top of that, if they have osteoporosis, it is like a bull in a china shop. Again, this is relevant. So this is relevant because now, this can be treated well. This can be diagnosed in advance and can be treated well. So there shouldn't be any problem. So, but the problem is that, less than 20% of these potential group get investigated. And when it comes to spine, the investigation of choice, that is DEXA, is totally misplaced. I'll tell you why. So even if you ask a small third standard boy, what is the definition of density of a 3-dimensional structure such as bone, it is length into breadth into depth. So when we do a DEXA, it is based on a AP or a lateral X-ray, which only assesses the length into breadth. So that is why it is totally misplaced. There are other pitfalls. So the reason why DEXA is commonly used is not because of any scientific rationale. It is because it is easily available, widely available. It is familiar with physicians, and it comes at low cost. We know that when there is osteoarthritis, which happens at the level of the facet joints, thickening of the lamina, again because of wear and tear, if there is a fracture, if there is a calcified aorta, one can get a wrong value. But in spite of that, we continue to do DEXA. The other pitfall of DEXA, as I said, is aortic calcification. If you go through the literature, about 40% of these patients in this age group tend to have a calcified aorta. Now, if you on the lateral X-ray of this same patient, you can see that you don't need a DEXA or a QCT. You can easily say that this patient is having osteoporosis. But if you do a DEXA, which is an AP X-ray, based on an AP X-ray, you will be doing a bone density of his aorta and not the vertebra, because you see here the aorta is totally calcified, and it is very much possible that you will get a wrong value. Same is with this particular picture here. So on the lateral image, you can see it is called a picture window frame, where you don't see the vertebral body. And in the AP, because of the sclerosis in the facet joints, that is the posterior elements which are irrelevant to our fixation, which are irrelevant to our compression fractures, you get a false value. Again, so obesity plays a role. Rotation of the patient plays a role in giving a wrong value. Again, if you consider lateral X-ray for your DEXA, if you are at the higher, on the upper side, you will have at L1, L2, you will have the overlap of the ribs, and lower down at L4, L5, it is overlapped by the iliac crest. So again, there is a high chance that you will get a wrong value. Now, we as spine surgeons know that 80% of the load, that is 80% of body's load goes through the anterior column. It's only the 20% that goes through the posterior column. And as we age, life is said to be a kyphosing event. And as you age, so you tend to kyphose. So the ratio can almost alter to 95:5. So we are interested in that 95. This is the vertebral body, the spongy trabecular bone. What you see in DEXA is basically a AP X-ray based view, which will account for the sclerosis in the facet joints, lamina, etc. So here if you see, so this is an interesting paper where they did a quantitative CT of each component, each element of the vertebra. If you see, the biggest is the weakest. The vertebral body, which takes the size of an elephant compared to the posterior elements, is the weakest because it has spongy bone, it is trabecular bone. About 70% of the anterior column has spongy bone in normal human being. And as we age, you can see this, even the spongy bone gets replaced, gets empty, and all we see is only vertical trabecular towards when they become elderly. So doing DEXA is totally misplaced. Trabecular bone is what accounts here. That is where the money lies. So that is where there are compression fractures. That is where you get pedicle screw loosening. That is where you get progressive kyphosis and sagittal imbalance. That is where you get flexion dominant pain. That is where you fuse. The anterior column is where you get a solid fusion, where you bank on a solid fusion. So in terms of osteoporosis, vertebral trabecular bone takes the spotlight. So optimal trabecular bone density is critical for the success of spinal fusions. So if you see here, this patient has osteoporotic compression fracture and the T-score is 1.5. And if you did when you did a quantitative CT of this particular patient, it was minus 3.2. So DEXA tends to give a wrong value. So again here, again a vertebral compression fracture minus 1.5. When we dug into it and got a QCT done, it's minus 2 and beyond. So as spine surgeons, we know that the strength of the pedicle screw is totally dependent on the strength of the vertebral body. The stronger the vertebral body, the stronger is the fixation. Again, it is known that osteoporosis hinders interbody fusion, and at the same time, it is shown that if you have good Hounsfield units in terms of a quantitative bone, you get better fusion. So that is when we embarked upon this particular study. Can I have 2 minutes?
No, not really. We are a very tight session, Arvind. We'll have to ask you to stop here. But fantastic talk. I think it's very evident and very clear in your message that quantitative CT scan has many advantages over a DEXA scan in assessing osteoporosis. Is this only restricted to the spine, Arvind, or would you extrapolate these results to the hip and the wrist like they do in the DEXA score?
The wrist is a controversial issue because it is not a weight-bearing bone, the lower end radius. So I don't know how relevant it is. When it comes to hip also, there also depends upon the rotation of the hip. You can, if there is a cortical overlap, you can get a pseudo value.
Measurement of a CT, quantitative CT, is through Hounsfield units, and yet the result is being given as a T-score. So is this being validated?
Yes, so that was my next slide. So it is validated.
It is validated.
Yeah, it is published in JBJSA.
Lovely. Okay, any other questions from anybody in the audience here for this excellent paper? Yes, Dr. Ingalalikar.
A lot of these patients, they have hypertrophic sclerotic facet joints. Therefore, the bone density could be higher. So we have started doing lateral view during bone density of lumbar spine. Results are still not available. But they do show a different picture than when you do AP PMD.
Yeah.
Yes, I think a very valid point, sir, but that's exactly what Arvind was saying. That
So there could be overlap of the iliac crest and the ribs, especially in patients with Degen's scoli, they will be as close as possible.
Lovely.
I would like to comment one thing.
Yes,
I think this is regarding assessment of patients who present to your clinic before surgery. I think that's what the topic was. I think the critical point here is that DEXA is only used for follow-up after the patient is on treatment. Trabecular score is one thing that can be easily assessed if you had done a CT scan. And if not, I think a DEXA femoral neck score below -2 is kind of a red flag beyond which you will need some augmentation techniques when you do the surgery on it. That's what practice I follow.
Yeah, so but why you take a surrogate value when you want,
If that is the only thing which is available.
Yeah.
If that is the only thing which is available.
Start doing QCTs, quantitative CTs.
I use a Hausenfeld unit. The cut-up mark for that is around 70. If it's below 70, Hausenfeld unit in the lumbar spine, then possibly patient needs some augmentation techniques.
Thank you, Arvind, for a wonderful talk. I would like to now invite Dr. Uday Pawar. All of us heard about the epidemic of osteoporotic fractures, and there was an epidemic subsequently at least in Bombay, of treating all of them primarily with vertebroplasty. Is this the right way to go, or is there something better on the horizon to treat acute osteoporotic vertebral fractures? Dr. Uday Pawar will highlight this situation.
So actually very correctly said. Thank you for Bombay Orthopaedic Society for the opportunity. So actually it was an epidemic of vertebroplasties that we all went through when this new modality started. And I'm sure my panel would agree, and most of us in the audience would agree, that after burning our fingers, we have come to a rational solution. And in this talk, I'm going to actually curb my surgical instincts and tell you that maybe, just maybe, teriparatide, just medical management would be a better option for an acute osteoporotic vertebral fracture. So let me put my reasons for this. So most of the times we know that a plain thoracolumbar osteoporotic vertebral fracture in that typical age group, it generally has a good natural history of healing. And most of the times, without us as well, they heal. You see patients coming in your clinic with an old healed fracture, developing new fractures. So actually you weren't there as well, and still these patients went on to heal, maybe with a little bit of a kyphosis, but they heal nonetheless. And suppose you think of getting an osteoporotic vertebral fracture, getting a vertebroplasty done, in a fresh fracture where the fracture lines are quite fresh and the cement, there's a high likelihood of the cement seeping anywhere. If it seeps anteriorly, you're still okay. But if it seeps posteriorly, you've had a nightmare of a problem where the patient came walking to you and now the patient probably risks a neurological injury. So that's really a nightmare and a complication risk which we all should take into account. Now going further, suppose you do a very well vertebroplasty and the patient, I'm sure the patient is happy, but many of the times the short term, the happiness can be very short sometimes, because if you don't treat the osteoporosis, the hard cement, the bone surrounding the hard cement just collapses, you get an infection, you get an adjacent segment disease. So we've had all of these issues where a short-term happiness led to a long-term disability to the patient. And let's face it, teriparatide works because it actually builds bone. It prevents new fracture, which maybe your surgical technique, very well done vertebroplasty, might not do. It gives pain relief, and in the long run is cost effective, saves the cost of a vertebroplasty. But it also gives an opportunity for you to investigate this patient further. Whether there is some infection happening, whether there is any super added, any other problems happening, it gives you chance to wait it out, start the patient on medical management, and see through it. And if you're one of those Casanova spine surgeons, that very few patients, most of us know that very few patients agree for a procedure right away when you tell them. So it actually buys important time, keeps the patient into loop, and maybe the patient is receptive more later on when you break the news that maybe that you're not healing 3 to 6 weeks down the line, and maybe right now is a better time for you to do some vertebroplasty or a cement augmentation of the vertebra. And also maybe sometimes just doing a vertebroplasty might not be a sufficient option for that patient. As we all know, these are thoracolumbar junctional injuries, and most of the times you have the middle column right sitting on the spinal cord, and maybe you need to do a decompression, add of instrumentation, and maybe just a vertebroplasty might not help that patient. So my verdict will be that in this scenario for an acute osteoporotic vertebral fracture, it's prudent for all of us to start medical management. Nowadays we have teriparatide, a wonderful chemical, and use the natural history to your advantage and to the patient's advantage as well. So most heal within 1 or 2 months, maybe a little bit pain or kyphosis, but they heal nonetheless. Investigate these patients fully, treat the osteoporosis aggressively, and follow these patients up regularly. And maybe this is one of the scenarios where actually the pen is mightier than your scalpel. Thank you.
Thank you, Uday. I think that was a point well made. I have a few questions. What about, is there any difference in the results between giving teriparatide every day versus weekly teriparatide in the acute vertebral fracture scenario?
Maybe that was studied in quite a few times in literature, and they've figured out that teriparatide given almost daily, because it's related to the hormone, parathyroid hormone. And if you have a pulsed hormonal release every time, it has better bone effect.
One of our co-chairmen is from the Los Angeles, I believe.
St. Louis.
St. Louis, and I'm sure in St. Louis they don't do this teriparatide business. They do vertebroplasty on day 1 because they want the patients up and about the next day. What do you think about this?
I think, I have a lot of disagreements with this talk. And just to give a balanced perspective, I'm not opposed to starting teriparatide, but I think the presentation here was versus kyphoplasty. We don't do vertebroplasties anymore. Kyphoplasty. I think it can be done with conjunction. It's not a question of either or. It's a good option to have if you cannot do a kyphoplasty. So, but again, there are a lot of nuances before we can go ahead and draw that comparisons. The nuances are what kind of osteoporotic fracture is there? You know, is there a neurology there? How is the patient general status? So there is a lot of work been done. There is a osteoporosis.
No, Amit, let's not talk about apples and oranges. You have to put your money where what you are talking. I think so what we are trying to say, what he is trying to say is, this is a compression fracture. There is no neurologic deficit, no ligamentous instability. You know this patient is going to heal on his own in 3 months. Are you going to treat this with a kyphoplasty, or do you think that teriparatide is enough or not? So that's the question.
I will take the liberty of 3 comments. Number 1 comment is that the literature is out there. There is a number needed to treat. The kyphoplasty is the most life-saving procedure that is available to orthopedic surgeon. The mortality benefit for 1 year is 55%. The reason is that patient have a terrible loss of muscle mass within 2 weeks. They risk a lot of isolation, depression, a lot of subsequent issues and adjacent segment fracture because mobility is totally lost. So if there is a patient who is not walking, I will jump onto kyphoplasty within a week. If the patient who is walking and tolerating, maybe I can go to other things. And the literature is out there, brace doesn't work. And the teriparatide, the literature is out there, it is less effective than kyphoplasty.
Just give time. Time works for most of these patients. Why jump the gun and do the vertebroplasty or a kyphoplasty?
There is a 20% loss of muscle mass because of immobility within a week. We don't have
Not
time.
necessarily you need to keep the patient immobile.
So that's
Once
what
the
I'm
patient
saying. If the
comfortable, he
patient
can
is
walk.
immobile, I will jump to kyphoplasty.
The
But
patient is not immobile. These patients, all you and me know that these patients are not immobile per se.
Dr. Pawar.
One
Dr.
question,
Pawar.
last question.
Yeah, so
Dr.
Dr.
Zaveri.
Satyan Mehta, spine surgeon here. I just wanted to ask you, since you're so aggressive with kyphoplasty on in the first week itself, do you actually clinically follow up these patients on your own, not with a general practitioner, on your own over the next few weeks? Do you actually see
we follow
them?
it over a year.
And you find that they do very well and they don't complain about pain
As I
and
said,
they're up and
there is a
about.
55% mortality benefit for a year. If the OF,
I'm asking about pain relief. I'm not asking about statistics.
pain relief is excellent. That is, I think, again, if you see the literature review, this as I
I'm
said,
asking your experience.
my experience is there is a wonderful pain relief.
Wonderful pain relief. They are up and about. And
And the procedure
Yeah,
I
I
do,
think we'll have to close this particular
the procedure I do is a
discussion
spine
here.
jack procedure.
So
sir.
while we can talk for hours together, we can talk in all four halls about vertebroplasty and kyphoplasty. I would like to invite my co-convener to talk on this particular situation wherein mostly one needs to do some kind of intervention to get the patient out of the well. Yeah.
So we move on to the talk where the German Trauma Society has classified osteoporotic vertebral fractures into 3 types. There is the first into 5 types, the OF1 and OF2, where there is no vertebral deformation, which is detected only on MRI, and OF2, which is where there is just a superior end plate, what we call as a wedge compression fracture. They say that these fractures are stable fractures and they can be easily treated non-operatively, or if there is a persistent pain, you can think of vertebroplasty for these patients. On the other hand, OF5, which is the last category, is treated because there is ligamentous instability, always requires surgery. The doubt and the debate is about OF3 and OF4 fractures. These are what we call as burst fractures. The posterior wall of the vertebral body has fractured, and therefore there is a danger here that there can be progressive collapse. There are studies which have shown that there is significant progressive collapse in patients who have pincer type of fractures, incomplete or complete burst fractures. And this is significantly higher rate than with simple wedge compression fractures. And therefore that question comes that if you have a stable burst fracture without a neurologic deficit, which was the scenario we were discussing in Uday's case, should we treat these non-operatively? Should we think primarily of cement augmentation as Dr. Bhandarkar has suggested, or should we think about surgery in these patients? Well, it is vital to know the natural history of any condition that you treat. If you have 100 patients of osteoporotic vertebral fractures, 63% of them will go on to normal healing within a period of 4 to 6 weeks. About 35% will collapse, of which 23% will go on to collapse healing. Collapse is a natural phenomena of the vertebral body because it collapses into stability. Your job as a spine surgeon is to prevent neurologic deficit during the time or significant deformity when the collapse is happening. Collapse is natural. What body is trying to do is achieve stability. May it be more longer collapse or lesser collapse. And only 15% of them develop a pseudoarthrosis, and only 3% of them develop what is called as a delayed neurologic deficit. So it is vital to know that 2/3 of your patients, the pain is going to reduce by more than 80% within 4 weeks of injury. And therefore, I strongly disagree with Dr. Bhandarkar here that every patient who comes to your clinic, just put in an injection there. The non-operative treatment is a very short period of bed rest. We should encourage patient to be mobile and active as much as possible, appropriate analgesia, osteoporotic treatment, isometric exercises, and bracing is mentioned. But in the burst fracture scenario, it is vital to do strict monitoring clinically to look for evidence of any neurology, which is very subtle in the early stages. and radiologically to see whether there is any significant collapse or further retropulsion of bone. As Uday mentioned, the role of teriparatide today is extremely well established in acute osteoporotic vertebral fractures. Daily teriparatide provides significant pain relief at 8 and 12 weeks following acute vertebral fractures. There is a significant reduction in vertebral collapse. There is a significant reduction in the incidence of vertebral pseudoarthrosis. Another paper, it is useful in the non-operative treatment of acute osteoporotic vertebral fractures, and the results are comparable to a cement augmentation procedure, whether it be vertebroplasty or kyphoplasty. However, in a burst fracture scenario, when you look at the long-term non-operative treatment outcomes, there is a percentage of patients who did not do well, and these were the patients who had burst fractures. So, there is going to be a small, about 25% of patients with burst fractures who will not do that well. They may have persistent pain, they may have significant limitation in activities of daily living. So if we can catch these patients, and if the patient is ready to go for something, we should think about a cement augmentation procedures. They can be safely performed even in patients with posterior vertebral wall fracture. Today, that is also well established that in acute burst fractures, we can easily do vertebroplasty or kyphoplasty without problems. It provides excellent and immediate pain relief in almost 95% of patients, and it helps to maintain the vertebral body height and kyphosis correction at 3-month follow-up. So there are ample studies, as Amit suggested, 97 patients, 109 fractures of incomplete burst fractures treated with kyphoplasty, excellent result. But you must note this last thing over here, and that is that there was a 48% risk of cement leakage, although most of the cement leakages were asymptomatic. Vertebroplasty, kyphoplasty, cement augmentation procedures of any type, wonderful results in terms of pain relief. I am a strong proponent of them, but remember that they are not without complications. There is a significant risk of cement leakage, not only outside the canal, but into the spinal canal. Having said that, the risk of developing a neurologic deficit is very low. The risk of cement embolism into the lungs is also extremely low. But another problem, as pointed out by Uday, is the incidence of recurrent pain following cement augmentation, because about 3% of fractures will further collapse at the same level. About 10% will develop adjacent level fractures, and 13% will develop remote fractures which can cause recurrent pain. When you compare vertebroplasty plus teriparatide versus vertebroplasty alone, the results were far better when teriparatide was included. The German Orthopaedic Society recommendations are that for OF3 and OF4, you must do primary surgical stabilization to allow early painless mobilization of the patient. So a number of surgeries have been described, something like this, which is a short segment fixation, or what I have done over there, a long segment fixation with anterior column reconstruction can be done. But you must remember that this is a group of patients who are elderly. They have multiple medical comorbidities. There is a high 30-day mortality rate after surgery. There is a risk of implant pullout. There is a risk, as Arvind pointed out, proximal and distal junctional failures and deep wound infection. Hosogane pointed out that in 403 patients, they had perioperative complications in 18% of patients, and their implant failure rate was 41%. Kono pointed out that in 38 patients with mid to lower lumbar burst where posterior stabilization was done, the post-op vertebral collapse was 30%, and their instrumentation failure rate was 37%. So these procedures, when you can do it, treat these patients non-operatively with a limited amount of morbidity, then I think this should be your first way to work. So if the burst fracture is a special fracture in the osteoporosis scenario, because it carries a higher risk of progressive collapse, chronic back pain, and pseudoarthrosis. However, even so, you must remember that the natural history of any fracture is to collapse to heal, and that 65% will heal, albeit with a small amount of collapse and a small deformity. But even with that, they are largely asymptomatic. primary treatment of stable burst fractures in my practice is non-operative with careful clinical and radiological monitoring. Thank you.
Yeah, Gautam, just a simple question. See, on one hand, you have a very benign, safe, 15-minute procedure with hardly any immediate complications such as vertebroplasty, which is done under local anesthesia. And when we can't predict which is going to land up in a collapse later on, and on the other hand, you have this complex surgery where you are subjecting this patient to general anesthesia, putting so many screws. These patients carry comorbidities. They can have higher and worse complications compared to the just vertebroplasty. Why don't do more vertebroplasties than conserve them and wait for them to collapse and then screw them with bad complications?
A very good question. I think Amit would very, very agree with you on that also. I think that's a fair question, and the jury is still out on this. There aren't enough good quality studies to tell you that this is the better. But having said that, I don't think vertebroplasty is as benign a procedure. Not in terms of the immediate complications in the risk of neurologic deficit or cement embolism. I'm not worried about that. But you do have an incidence of collapse of the same vertebra, adjacent vertebra, resulting in recurrent pain in these patients also. So it is not as benign a procedure as it is made out to be. And therefore, you must take this with caution. So when you are advising the patient, I like to leave the decision making to the patient. That look, these are your three options. I feel a vertebroplasty may be a good way to go, but you can get recurrent pain within 3 to 4 months after this vertebroplasty. We'll put you on teriparatide also, but yet there is a risk you might get it. Are you willing for that, or would you like to wait for 3 to 4 months and let your pain settle down? It depends on the patient.
So that's one shouldn't pull someone down because he does early vertebroplasty. I mean, if you have a frank discussion with the patient, it can be one of the options. So there are many options of, when you're treating a particular patient.
I would like to put 3 comments, quick comments. I think excellent DGOE classification is a very good classification. It has a great importance because what it is doing, it is stratifying the fracture. So I don't treat every fracture with kyphoplasty. So if it's 3, 4, or there is a scoring system like the TLIC scoring system, if the score is more than 6, then only a kyphoplasty is justified. But if the score, if the patient has a type 5, then definitely sometimes it requires a stabilization. Other qualifier I want to say is that there are a lot of refinements in 2 things. First is cement. I don't mean to, so I think some general public have a assumption that we don't use that CMW3 cement as vertebroplasty anymore, and we note those complications. The cement that I use, I don't think so I have any leakages. That 40% is pretty high leakages.
Those are probably old studies from 2008 and 2012, and I would agree with your results that now the cement which we get is minimally spreadable, and it hardly
it's very pasty.
As I said in my talk, I am not at all worried about cement leakage. I am more worried about the fact that there is not adequate pain relief because of adjacent level, same level, or remote fractures.
And the 2 things, one more I want to add is that the second nuisance that we don't consider is the element of kyphotic angle restoration. Vertebral height restoration is a different thing, but kyphoplasty, why it is important is that it restores the angle. For every angle...
So that is very controversial, Amit. I'll stop you here.
So I think,
because you are putting a comment. It's not a question.
Vishal,
if it was a question, I would have agreed to listen to you. But since it's
Dr.
a comment,
Javeri,
so kyphoplasty...
Sorry, sir.
So we have to stop.
The timing.
Just want to add to what was going on.
We are running short of time.
In the meantime, as Vishal comes up on the stage, sir, you can go ahead with your question.
Okay. All these patients, when they come back with a little bit of collapse of the vertebroplasted vertebra, you must do a sitting X-ray lateral view, shoot through. You must do supine lying, shoot through. You will find in many cases a space between the blob of the cement and the place where it is. So it's only mechanical stacking rather than the bone getting incorporated into the cement or cement getting incorporated. Sure. These are the ones, especially if they're reached anteriorly, they are likely to extrude out today or tomorrow.
Yeah, so this usually depends upon the indication. If it is bone edema where you're injecting your cement, then such a situation doesn't arise. When you're injecting in a cleft, so that is when such a situation arises.
Very often, after we do a procedure, we go to sleep and not monitor them.
Need to move ahead.
Yeah, so we need to know, in case vertebroplasty fails, we need to put screws, and that is where Vishal Peshettiwar is called. So, Vishal, will you do a open or percutaneous in osteoporotic bones?
Depends. Hi, good afternoon. Well, open pedicle screw in osteoporosis will probably plug every pedicle that's there from cervical to the sacral segments. How do we make them safer in osteoporotic? Try to make a smaller pilot hole. Don't tap whole way through, just do initial tapping. Use fatter and longer screws. A fatter screw is stronger than a longer screw, remember that. So try to take the biggest bite out of a pedicle, but don't stuff the pedicle. If you have a pedicle that is 6 millimeters, you cannot put a 6.5 millimeter screw in there. It's not a pediatric pedicle which will expand. It's an old, stiff and soft pedicle which is going to burst. So optimal screws size should be used. Use more screws. More screws gives you more stability, and of course use cross connectors and other augmentations. Arvind doesn't agree with this, but it has some evidence behind it. Hooks, wires, and augments are a great help when you are doing. Augments like bone cement, bioactive glass, allografts, expansile screws, wires, hooks, and tapes help when a situation goes out of hand. This is not exactly osteoporosis, but the bone was similar. Very bad case here. You can see the center has no screws because all of them plucked out when we tried to correct it. And the thing that saved the day was those sublaminar wires. So how do we get out of a loose spot with stuff that's easily available? Stainless steel wires and hooks are some of the best augments you get, and they increase the stability of a pedicle screw by 60% and are nearly as good as tricalcium phosphate cement. Allograft, I've been guilty of using grafts in pilot holes and then putting a screw inside. That unfortunately loosens your hold because a pedicle gets its hold. There is a tube in which you put a screw. The screw, as you thread it, as it goes through its pitch, will give an expansion force and the pedicle compresses on it. When you put in a graft, that graft crushes the structure that is innately there in the pedicle and destroys it and reduces your hold. So don't use allograft or autograft to put inside the bone for augmentation. PMMA has the best augmentation force, that is, you should use it judiciously. Well, can you take it out? You can take it out, and the optimal study says 2.6 ml per screw, but practical experience says 1.5 to 2 ml in Indian pedicles is more than enough. Otherwise, you're going to have cement that leaks. Also, look at screw holes. Sometimes in short pedicles, the holes from where cement comes out might be in the pedicle area. You would want to avoid it there. Except for CPC, all other cemented screws can safely be backed out. You just need a sharp tug to break the cement interface and it comes out well. So where do you use percutaneous screws? For the beginners, at least short fusions, 1 or 2 TLIF levels. Fragility fractures is temporary spanning fusions and a part of hybrid fusions. Well, why should we use pedicle screws? As orthopedic surgeons treating ankle fractures, the same deforming force produces different fractures in young and in old. The reason is the yield strength of the ligament and bone is different when you are a young, robust man and is different when you are an old man. The same rule applies to spine. When you're doing an MIS procedure, the ligaments, the capsules, and the muscles are left far more intact than an open procedure. This gives an additional security to the bony purchase that you have. The morbidity is, of course, less. Mobilization is very early. And if you're worried about the hardware, you can take it out once your index job is over. You should use a mallet, a good C-arm. Navigation is better. Guide wires, you need to be careful of. You should mark your landmarks. Align your screws for multiple level, and please take your time. There was a famous line by someone that I can finish this in 10 minutes. There are only stupid surgeons who do fast surgeries. You should never do fast surgeries in today's age of safe anesthesia. You should take your time and do a proper job. Well, how does this help? This is a Brown's tumor, a pathological fracture in a renal patient awaiting transplant. This is tricalcium phosphate cement after an kyphoplasty through this incisions. You can see the black part there, that's the cement there. And this is his X-ray 8 years down the line. He recently passed away because of medical complication, but this case was done by me and Dr. Devesh in 2013. He lived for nearly 9 years post this and could be ambulatory and go for his dialysis. Another long segment, so there's a relative contraindication to put long segment fixations. This is a syndromic spine, dish-like picture. And that's what we did. This is with the old Legacy 1 system. And I had an excellent friend guiding me through this surgery. So we could get through. That's the union at 3 months. Otherwise, this guy, 120 kilos, there was no way you could have conserved. An open surgery would come with its own morbidity. Well, this is another burst fracture scenario in a post-COVID, on steroids, very fat lady, in severe pain 2 to 3 weeks post-surgery. We use what Gautam calls the cheat screw inside the fractured segment, augmented the same vertebra through a small hole through the pedicle, and that's the result. Implants, in such cases, you can take the implants out at 6 months to 1 year. Only thing you should do is keep the screws in, because the holes that the screws will leave inside would actually be stress risers and cause stress fractures. In young people, you should take it out, but in the elderly, leave them in. Another case for a hybrid fixation, this is a vertebroplasty done by an intervention guy in a TB spine, that's his MRI. This is what we did for him, because there's no way he could undergo an open surgery. His INR was more than 2.5 when we were operating. And that's what we did. So this aligned holes, we put in this scaffolding. The liver team went in, did a liver transplant, and after that we went in from the front, put in a cage, went back, revised it, and that was the end picture. That's this clinical picture. So augments are good when you are doing an osteoporotic fixation. They are, cementing is available as an option even in percutaneous screw. Go longer with your construct, keep hooks and wires standby. Anterior support is necessary. Your screws are not going to do the job that an anterior structure, weight-bearing structure does. So please reconstruct that. Don't leave it to the screws. Ligaments are stronger in the elderly. Preserve them. And of course, like Uday said, use anabolic agents as an adjunct to your surgery to improve the outcomes. Thank you.
Vishal, a quick question here. When we are doing surgery in the osteoporotic spine, we are a little worried about pull out of the pedicle screw when we are assembling the rod systems. Now, in a percutaneous screw fixation, we are not able to control the screw, the rod. The rod has to be put down to the screw, so the screw gets pulled up. Whereas when you have it open, you are contouring the rod perfectly so that you are not pulling it out. So how do you kind of account for that? Because you are worried about screw pull out when you are trying to reduce the rod to the screw.
As you do more and more, you would contour, the profile. Navigation helps because you store each screw. There are newer devices where you can actually bend the rod according to the screw that has been left behind. But what we do is we see the sagittal profile once all the screws are in and bend our rod accordingly. And you've seen this last case, I think Devesh and I did it in 2012, the long one. And it still got there, and it was bad bone. So the trick is not reducing the rod inside. You have to get the rod right close to the tulip. Maybe if you're using a legacy system, it should be at 4. So that 4 millimeters it will take. But if you're going to reduce it from a 32 to 4, the screws are going to get plucked out.
Time. So we'll invite the next speaker, Dr. Manoj Chadha. He is going to tell us about whether it is important to take drug holidays or just continue with drugs as sequential therapies for osteoporosis.
I don't know why you put my last slide first, or is it a sign that I should move out? Hey. So thank you for having me here. I just realized I'm the odd one out, the knave physician. For me, screw has a totally different meaning. So let's talk about severe osteoporosis and what are the options that we have with us. I'm going to define what is severe osteoporosis, what are the options that we have with us, the importance of sequential therapy, a little bit about drug holiday because we can't use it in every patient and then get the thing sorted out. I put a case vignette here to define severe osteoporosis. A patient who's had more than one fragility fracture or who has a T-score which is less than minus 3.5, that would be considered as severe osteoporosis. And just to put the things in context, the BMD by DEXA is probably the gold standard because that's the one which is widely available. And when you talk in terms of follow-up, that's the only tool available. You cannot use the other methods for follow-up. And why are we worried about fragility fractures? I think this slide explains to you that one fragility fracture begets another fracture. and the highest chance of a fracture is within the first year of the fragility fracture. And we are working all over the globe, including India, for fracture license services to reduce the incidence of fragility fracture. In terms of treatment options, as we've looked at most of these presentations, and there have been severe osteoporotic fractures, you should look at the anabolic treatment as the first choice. Today, we have teriparatide as the only option, but hopefully in the next 6 to 8 months, you will have romosozumab also available in India. They have good experience in the US, parts of Europe, and a lot from Japan, and they really do well. Just to introduce you to this drug, it's a Wnt signaling, it's a sclerostin antagonist. Once a month for 12 months, that's what's recommended. Teriparatide, I think all of you are familiar with, so I don't need to go into details. In terms of anti-resorptive agents, today the major chunk of patients either receive bisphosphonate, whether it's oral or parenteral, or denosumab. You must have heard a lot of studies in terms of reducing the fracture risk, then denosumab data, freedom, data switch. I'm not going to go into those. There's 2 or 3 interesting studies that I have put up here. One is the STAND study, which is 500 patients of postmenopausal osteoporosis divided between alendronate and denosumab for a period of 1 year. And as compared to alendronate, the response to denosumab was much better, nearly to the tune of about 50%. As I mentioned, the new data is on romosozumab. Here we are looking at 2 years of treatment, although the recommendation now is for 1 year. And the important thing is that in patients who continue to receive denosumab, the BMD continued to increase, whereas those who were receiving placebo or the treatment was stopped, the density decreased. The important point to consider here is that anabolic agents work only till they are given. Once you stop giving them, the bone density again starts declining. And that's where the importance of sequential therapy comes in. This short study again looks at 2 sets of patients, romosozumab for 12 months versus placebo, and then they followed up for another 12 months of either denosumab and placebo, and you can see the reduction in the BMD with placebo, whereas with denosumab it increased, and then a repeat course of 1 year of romosozumab further increased the response in terms of increase in BMD. The freedom study, I think everyone is familiar with 10 years, freedom and freedom extension, 10 years of denosumab treatment, and the frame was with romosozumab. And the fact is that with the green beads, that is the continuation of denosumab after the use of the anabolic agent, the bone density continued to increase for a period of up to 10 years. Sometimes we discuss zoledronic acid versus denosumab. Zoledronic acid is good in terms of increasing BMD for 3 to 5 years, and after that it stabilizes. Whereas with denosumab, it continues up to 10 years. And why we should not stop it, I think the data from Freedom is very clear. Those patients who stopped, who are not given treatment anti-resorptive after denosumab, the BMD at the lumbar spine and at the hip continue to decrease. Question that comes up is what sort of sequence we should be using. I think a simple answer is go with anabolic first and then follow it up with anti-resorptive. But very often patients are not ready for the anabolic treatment at the beginning and would like to use the anti-resorptive option first. So what has come out from the various studies is that if you're going to go from alendronate to teriparatide or risedronate to teriparatide, the first 6 to 12 months you may be actually wasting, in the sense the BMD goes down and then it increases after. So it's not that you can't do it, but whereas if you're using a denosumab, which has a shorter memory, this loss of time is less, but it is also there. So the important thing is anabolic therapy should be followed by anti-resorptive therapy. Anti-resorptive therapy, if you're going to follow it up with an anabolic agent, then probably using denosumab is a better option. What about stopping therapy, drug holiday? I think if the patient responds to treatment and has done well, the BMD score has gone above -2.5, and you are using a bisphosphonate, you can think of a drug holiday. There is no drug holiday for a monoclonal antibody like denosumab. You can follow these patients with bone markers and BMD every 6 to 12 months, bone markers every 12 to 18 months, BMD. And if there is a fall in BMD, if the patient fractures or if the anti-resorptive markers are increasing, you need to restart your therapy. The important thing is discuss the therapy with patients. The duration of the treatment is very important. And unless they take the treatment, it's not going to work. So compliance is very important in selecting our patients. Thank you very much for your patience.
Thank you, Dr. Chadha. We have a question quickly. Amit, first.
Dr. Chadha, so basically, what's the deal with this taking the teriparatide continuously for 2 years? I mean, if you stop, can you restart them or can you introduce them at a later part of the life?
Yeah, so 18 months was what was initially allowed by the US FDA. It became 24 months. Now it is 30 months with glucocorticoid-induced osteoporosis. The black box warning for osteosarcoma has been removed now. So if someone says, I want to give it for 5 years, it is possible. The thing with anabolic therapy is that it increases bone formation. But at the same time, within the next few weeks, there is going to be bone resorption because formation and resorption and formation are connected to each other. So if someone says, I want to give teriparatide for the next 5 years, I'd say probably you're wasting your time because after about 18 or 24 months, if you look at the bone turnover markers, they start decreasing. So you would not get any benefit. Yes, you can give it for 1 year, take a break and again give it for 1 year, but with an anti-resorptive in between.
Okay.
Thank you very much, Dr. Chadha. That was a lovely talk. Please take a chair here. There are a lot of questions, both from the panelists, the chairpersons, and even from the audience, which people would like to take. But for shortage of time, we'll take it during the lunch break. Can we invite Dr. Agnivesh Tikoo to give his talk on how to monitor osteoporotic therapy? There is a senior urologist. His wife was 60. She had an ankle fracture, 3 osteoporotic vertebral fractures, was given denosumab for 1 year. And she was very upset when she did the DEXA scan after 1 year because the bone densitometry showed the T-score was exactly the same. So she was in tears and, my therapy is not working. So is the therapy not working, Agnivesh, or is the way to measure the outcome different? That's what you have to speak.
Thank you very much, Gautam sir, and thank you, organizers. So I'll be speaking on this topic of monitoring. So monitoring is by 3 methods. One is the clinical improvement. The second is the investigations. And the third is the side effect profile. These 3 things are key to be monitored whenever a patient is on anti-osteoporotic therapy. So clinical monitoring in patients can be by clinical methods, wherein people who are severely osteoporotic, especially very thin, lean ladies, they will report improvement in general bone aches and pains clinically when they start getting better. Prevention of new fractures does not happen immediately as soon as you start the anti-osteoporotic therapy. There is a time lag before the effect starts taking place. For teriparatide, it's around 8 months, and for bisphosphonates, there are criteria that you should have 2 or more incidental fractures in the therapy and decrease in BMD, which is more than least significant change. So least significant change is basically to rule out an observational error and that you are not measuring, sort of wrongly labeling the observation error as a change in the test. A key point is while doing vitamin D and calcium test that use the albumin correction to find out true calcium because that will change your whole diagnosis as well as your treatment. So DEXA is to be done ideally at 2 years because it reflects the changes better at 2 years. The least significant change is better covered up. And in rare circumstances where you're following a patient who is instituted on high-dose steroid therapy, you may want to repeat it at 6 months to sort of document the bone loss and start. Although there are clear guidelines that longer than 3 months, you have to start them on some prophylactic dose of anti-resorptives. So coming to the question which Gautam sir asked, that the T-score was the same. So we only do not have to look at the T scores, we also have to look at something which is called as Z scores. So Z score is age matched. So even though the T score may be the same, but the Z score may show improvement. So that is what you have to tell the patient, that your T score has not worsened. Remaining same also means that there is improvement. You have not deteriorated with the age. Bone density cannot differentiate between osteomalacia, osteoporosis, or other bone diseases. So this has to be considered. Bone turnover markers, which we have started using now in our practice. There are a lot of bone turnover markers, but they can show you the effect of bone density, sort of the improvement in with drugs earlier. Around 3 months is the time when you usually do them. Depends upon marker to marker. So the resorptive markers, which usually are the beta cross labs or CTX, you have to do fasting, and there is a lot of circadian variation. Urine sample, better 24 hours, because that reflects better. It's independent of low creatinine ratio, which may be there in sarcopenic patients. P1NP has less circadian rhythm, so you can probably do it at any point of the day. And the other markers are also there, which are affected by these lot of factors. But the ones I mentioned are the ones which we need to be very careful about. Fractures during the course of treatment may affect bone turnover markers, so then they become sort of invalidated. You don't know what's going on. If the patient develops a fracture, then it is going to increase. So the recommendations are for bone formation, CTX is, for resorption, CTX is better, and P1NP is the one we usually follow because it's more easily available. 12 weeks is usually the cutoff time, which has been shown by Trio study, that most 80% of the bone turnover markers show a good change. So 3 weeks is the time when you usually do them. Denosumab has been shown to suppress bone turnover markers better than bisphosphonates, and that's why it turns over to a better sort of a bone density change at the end of 1 year. Yeah. So, one key point in teriparatide is that don't measure calcium levels immediately after giving teriparatide, because there's always some transient hypercalcemia which happens. So give a gap of 8 hours between doing that. And P1NP again, measure at 1 to 3 months. Usually it's the time when it peaks, the least significant change being 20% from the baseline. Do baseline P1NP predict fracture risk? The answer to that is no. So the take-home message is that BTM can help us to understand response to therapy as early as 3 months. They help us to identify non-compliance, non-responders. They correlate better with spine, to some extent with hip, but not at other fracture site. DEXA is the gold standard. We need to sort of stick to that. CT DEXA, as said, is promising. Problem is availability and interpretation. Thank you.
Thank you very much, Agnivesh. Any questions for Agnivesh from the audience or from the panelists here? Amit?
I think I was trying to make a comment on the previous one. Is that
Go ahead. Now this
so,
is the time.
you know, it's very promising, Romosumab. You know, I have a personal experience with that. Any patient who I fear that has osteoporosis before doing any degenerative surgery, we start them for 6 months, and I have noticed a phenomenal difference. And the sequential therapy is going to change a lot of outcomes. So I think Evenity is really promising, and the sequential therapy is the future. Before treating any degenerative spine in the future, we will definitely go with the sequential therapy. I think that's what is coming. And I have seen, but I think the insertional torque in the pedicle screws was amazingly different than what I anticipated based on the patient presentation 6 months before. It's amazing. So
Thank you very much to the audience for a patient listening. If there are any questions, we are here during lunchtime. We would be happy to answer the questions. I hope this has cleared some basic doubts regarding the medical treatment of osteoporosis, perioperative management, the management of acute osteoporotic vertebral fractures. Thank you very much. I would like to thank the panelists and hand the mic over to Dr. Mamtora.